కాదు ఎంజిటికి టీబీ ప్యానల్ ఇంకో శాంపుల్ తీసుకుంది.
ఓకే సార్.
ఇది హిస్టోపాథాలజీ కదండి.
Can I start? Yeah. Good evening, everyone. So my topic will be short and. Hello. Can I start?
Where is that paper?
Good evening, everyone. My topic will be short and just I'll be brief about what will be the role of FDG PET-CT in sampling and guiding the EBUS. So before I start, there's short introduction about PET-CT. PET-CT itself is a hybrid modality which incorporates the two different techniques, which one includes it and PET scanning. So it involves the three steps. First is the injecting a radiopharmaceutical to the patient, then going ahead with the acquisition scan, and then following that the assessing and the interpretation of results. So the most common radiopharmaceutical used in PET-CT is fluorodeoxyglucose, which is also known as FDG. So this is a short illustration of how the PET scans are done. The patient will be injected a radioactive material, and then there will be a 45 minutes of waiting, followed by scan acquisition for 5 to 7 minutes, and followed by that the image reconstructions and the interpretation. So
Next. Yes, sir.
So here is one of the questions that which radiopharmaceutical you think is most commonly used in PET-CT for the imaging?
Sir, after this we have two more
Messages. Sir, 1 minute.
I don't have
Sir, this is one better. Yeah.
Yeah. So coming to the next slide. So congratulations. So coming to the next slide. So this is how the FDG is internalized into the cell. So basically the FDG is a glucose analog, and it is internalized by the cell through the GLUT receptors. So and after entering into the cell, it enters into the HMP shunt, where the glucose is phosphorylized to glucose 6 phosphatase. Same, the FDG will be phosphorylized to FDG 6 phosphatase. But the difference starts there. When glucose is internalized, as the cell recognizes the FDG is a different chemical from the glucose, and it will not enter further into the glycolytic pathways. While the step that make the difference is the cancer cells or the inflammatory cells will have very less amount of dephosphatase enzymes. So this FDG 6 phosphatase, which is and it cannot come out because of the lack of significant amount of dephosphatase enzyme, and it will be trapped inside the cell, while the glucose will be dephosphorylized and it will come out of the cell. So that's how we can make a contrast between a pathological cell and non-pathological or a physiological cells when we are doing a FDG PET scan. So this is the next question regarding the internalization of FDG, and you can give your answers. So coming to the next slide. So why does or when does the cell concentrate FDG? So they will have increased glycolysis if they have higher expression of GLUT receptors on the cell. if they have a differential ratio of hexokinase and phosphatase. Hexokinase is for internalization, phosphatase is for dephosphorylation. So usually this is very commonly seen in the cancer cells, which will help us to which helps to internalize FDG and increase the concentration of the FDG into the cells. So now the role of FDG is completely established in cancer imaging, but day by day its utility in the infection and inflammation imaging is increasing, and the main reason for that is the accumulation of FDG cells into the lymphocyte, fibroblast, macrophages, neutrophils, and all forms of inflammatory cells, and this is in spite of the patient blood sugar levels. So this is just a representation. When you see a viable cancer cell, the amount of FDG taken by a cancer mass, the viable cell concentration will be 90% or more. But if you remove these cancer cells, the next cells which will concentrate maximum of FDG will be the inflammatory cells or the fibroblast. So these cells needs to be considered when you are imaging with FDG. So next question. That's good. One more time. So this is how a normal PET scan will look like. So I'm putting this image here because specifically I want everyone to know that there are few sites which will always show a physiological FDG uptake: the brain, the myocardium, the liver, spleen, kidneys, and the bladder. So these sites may be as hot as pathological lesions. So whenever you read a PET scan, these things should be considered, while that you should be able to differentiate between a physiological and pathological uptakes. So coming to our topic now, the causes of mediastinal adenopathy, though that we know that there are malignant causes and there is a bigger list of benign causes in the mediastinal lymphadenopathy, and we will need some modality which will help us to decide that does these lymph nodes will require a intervention or a pathological approach to identify if these are malignant or benign, or so. The role of FDG PET in metastatic nodal disease or metastatic mediastinal nodal disease is already established, and it is used for the staging of cancers, and also used for the assessment of treatment response, also used for the guiding biopsies. But many a times this role can be misleading because of the hyperplastic thymus or inflammatory lesions, or sometime a physiological uptake also. So one should be aware of the inflammatory activity in the mediastinum. So this is one example of PET scan which is showing left hilar mass with a large bulky left hilar lymph node, which makes it N1, but then the PET was showing a positive lymph node at the 4R, which is makes this N3. So PET here in this case there was no N2 node. So this makes PET scan very important, that when you are seeing a changing a nodal stage and particularly changing the therapeutic approach in such patients. One more example of lymphoma showing different mediastinal lymph nodes, subcarinal, hilar. Another example of CA breast showing again the hilar and subcarinal lymph nodes as metastasis. So we already have the established role of PET-CT in metastatic disease, but the non-metastatic disease there will be a significant utility initially in initial diagnosis, as well as assessment of extent of disease, then guiding the specific sites of biopsies, assessment of response to the granulomatous disease, and important role will be to act as a non-invasive lesions, where you should go invasive or not, to take a decision on that, like to see if you see a uptake in an inflammatory lesion, or if you don't see uptake, those benign lesions like cyst or hematomas may not require any intervention, and they can be just followed up with the imaging. So coming to next question. It's well understood. Winner again. So coming to some of the examples, this is a mediastinal nodal disease there is also a bone involvement in a tuberculosis. Then this is a case of sarcoidosis which is showing multiple site involvement, and we can also see the periportal node involvement in the whole body PET. So the most common question we come across from many physicians, that what is the cutoff value of SUV when you see a FDG PET to differentiate between the malignant and non-malignant lesion. So few books and few literatures have suggested a 2.5 as a cutoff, but it is not correct. There is no as such a cutoff value for differentiating between malignant and mediastinal nodes. So there is one thing, that with increased uptake, the chances of lesion being malignant, or the higher the SUVs, the lesion being malignant will be more. But I will show you some examples, like this is a case of right lung with hilar mass, hilar lymph node and subcarinal lymph node. SUV is 6.8. Case of tuberculosis, SUV is 8.3. Case of sarcoidosis, SUV is 9.8. In case of lymphoma, they all four look same, they all show uptake, they all shine, and they have different SUVs. So SUV should not be a cutoff value to differentiate between a malignant and non-malignant lesion, but SUVs can help to decide which nodes to biopsy, which nodes to sample, because higher the uptake is directly equal to the higher the cellularity in the lesion, and it will give the highest yield. That was for their reference actually. Fine. Coming to the next slide. So when the FDG will be helpful, how the FDG will be guiding in EBUS and TBNA. So what the EBUS or the pulmonology guideline says, there are multiple indications for EBUS, but I have just brought the 2 points where you can incorporate the information from FDG PET while you are going for TBNA. So these are the 2 points where specifically these are concentrated towards the staging in lung cancers, where there are N1 large hilar nodes or critical hilar nodes, or there are mediastinal lymph nodes, and there are central tumors. But similarly, what the PET guidelines also says is, if a PET negative node is less than 15 millimeter, it should directly proceed to surgery, and those nodes which are greater than 16 millimeter but not showing uptake should require a histopathological proof. Again, a PET positive node which should be sampled if it is going to entirely change the treatment parameters of the patient. So this is example. This is case of CA lung with subcarinal lymph node, making it N2 disease. But this whole body imaging also revealed some right supraclavicular lymph nodes and para-aortic lymph nodes. So in this case, you may not go significantly invasive, and sampling from supraclavicular lymph nodes may be helpful. Secondly, this is one of the case with right hilar mass and a hilar lymph node. We are also seeing a lymph node in the precarinal region and left hilum. The right hilar lymph node has the exact uptake matching to the hilar mass, but where the precarinal and the left hilar lymph nodes have the lower FDG uptake. So these lymph nodes will be requiring the sampling to confirm with the staging of the patients. I can skip this slide. So coming to a review of literature, there are very few studies which are directly comparing the EBUS TBNA with the FDG PET finding. So this is one of the largest study where they have compared the patients which are having T1 and T2 lesions, and they did EBUS and the sampling of the node, EBUS and TBNA, and those results were compared with the PET positive results. So what they found significantly is those which are T2 tumors will have N2 disease very commonly. Solid tumors will have N2 disease. Central tumors will have N2 disease which are negative on PET, that is like 17.5%, and almost these solid central T2 tumors, it's all together all 3 points, where the 33 patient may have negative FDG PET but positive EBUS TBNA findings. So specifically going for when the imaging shows a central tumor, solid tumor, or a tumor which is of more than 3 centimeters, usually you should go for EBUS. The final recommendations were lesions with T1 and T2 and having ground glass appearance in periphery does not require EBUS if the PET is negative, while the central tumors which are having even negative lymph node should go for the PET negative lymph node should also go for EBUS when there is the risk of these node being positive will be more than 10%. The another literature which I found interesting is in this they compared the the endosonographic findings of the EBUS with the other modalities, and they have compared the only endosonographic finding like the node size, the node preserved with fatty hilum, the shape of the node with the other parameters like CT size and PET size. So they found 3 very important variables where the central location of tumor, again the node enlargement, and again the FDG avidity in the lymph node, which has reduced the negative outcomes of EBUS and EUS and EBUS findings.
Hrushiakesh sir, so after this, can we just quickly wind up because we have a lot of other
Yes, sir.
cases
Finish the
also.
last slides.
Yeah.
So, so we the one interesting finding we have come across when we do PET after the EBUS, it was said that the EBUS may introduce some inflammation into the sampled node and may give PET positive results, and some cases were published for that. But when we come across the few of the literatures which were published and which suggested that if you have done the EBUS first and PET negative, the false positive rate was around 23%, which was less than doing PET first and then EBUS. So sequence of EBUS and PET doesn't usually matter. Even if the PET is done the EBUS is done between 30 days of PET CT, it should not alter the false positive or false negative rate of the study. But we would still recommend doing PET CT prior to EBUS, as it may preclude the requirement of EBUS if there is extra thoracic disease, and sometimes it may guide into the PET guided biopsies. Thank you.